Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 369 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. My first question to you reads, TOT, a 63-year-old man with end-stage renal disease caused by diabetic nephropathy, is receiving chronic ambulatory peritoneal dialysis. Because of dietary and fluid non-compliance, TOT complained of shortness of breath, abbreviated as SOB, and his dialysis prescription was adjusted to include 6 cycles of 2.5% peritoneal dialysis solutions. Today, his laboratory values are as follows. Sodium levels of 128 milliequivalents per liter. Potassium levels of 4 milliequivalents per liter. Chloride levels of 98 milliequivalents per liter. Total bicarbonate of 24. A BUN of 50 mg per deciliter. Creatinine of 6 mg per deciliter. Glucose levels of 600 mg per deciliter. I would like you to evaluate TOT's plasma osmolality. What is the etiology of TOT's hyponatremia? TOT's effective plasma osmolality is calculated to be 289 milliosmoles per liter, of which 33 milliosmoles per liter is contributed by the hyperglycemia. The slow utilization of glucose, because of the lack of insulin, causes water to move from the intracellular compartment into the plasma space because of the increased tonicity, thereby lowering the plasma sodium concentration. Despite the lowered plasma sodium concentration, the plasma osmolality is normal because of hyperglycemia. Hence, no symptoms attributable to hypoosmolality are observed. Indeed, when serum glucose is normalized with insulin and hydration, the serum sodium level will increase to approximately 136 milliequivalents per liter. For each 100 mg per deciliter increment in serum glucose, serum sodium decreases by 1.3 to 1.6 milliequivalents per liter. Use of hypertonic mannitol or glycine solutions in patients with cerebral edema also results in a hyperosmolar hyponatremia. The next case reads, QUB, a 30-year-old male athlete who has had multiple bouts of diarrhea for the last several days, has been drinking a sports drink to keep himself from getting dehydrated. His vital signs include supine blood pressure, 145 systolic 80 diastolic, and pulse, 70 beats per minute, standing blood pressure, 128 systolic 68 diastolic, and pulse, 90 beats per minute. Respiratory rate is 12 breaths per minute, and he is afebrile. His skin turgor is mildly decreased and laboratory data are the following. Sodium levels of 128 milliequivalents per liter. Potassium levels of 3.0 milliequivalents per liter. Chloride levels of 100 milliequivalents per liter. Bicarbonate levels of 17 milliequivalents per liter. A BUN of 27 mg per deciliter. Creatinine of 1.2 mg per deciliter. Urinary sodium and chloride were both less than 10 milliequivalents per liter. Assess QUB's electrolyte and fluid status. So my question to you is, what is the etiology of QUB's hyponatremia? QUB has true hypertonic hyponatremia with extracellular fluid depletion, suggesting that his total body sodium deficit is greater than that of total body water. His poor skin turgor, orthostasis, prerenal azotemia, and low urinary sodium are consistent with volume depletion. The urinary sodium concentration helps distinguish between renal and non-renal losses that result in the sodium and water deficits. When the plasma volume is depleted, the urinary sodium concentration is less than 10 milliequivalents per liter, suggesting appropriate renal sodium conservation. This is usually seen in patients such as QUB with GI fluid loss, as in vomiting, diarrhea, or profuse sweating. Other causes of hypertonic hyponatremia are less likely in QUB. They include surreptitious cathartic abuse and third spacing, or accumulation of extracellular fluid in the abdominal cavity during acute pancreatitis, ileus, or pseudomembranous colitis. If the urinary sodium is less than 20 milliequivalents per liter in the face of volume depletion, renal salt wastage should be considered. The potential causes of this latter problem include diuretic use, adrenal insufficiency, and salt-wasting nephropathy, e.g., chronic interstitial nephritis, medullary cystic disease, polycystic kidney disease, obstructive uropathy, and cisplatin toxicity. In patients with renal insufficiency, neither the urinary sodium nor chloride concentration is a reliable index of volume status. Volume depletion leads to increased reabsorption of sodium and water in the proximal tubule and, thus, decreased sodium delivery to the diluting segments for free water formation. Decreased effective arterial volume is also a potent non-osmotic stimulus for antidiuretic hormone release. These factors combine to dampen the ability of the kidney to form dilute urine and result in high urine osmolality despite a low serum sodium concentration. Although the fluid lost in diarrhea is hypertonic, it is the replacement of fluid lost with an even more hypertonic fluid such as the sports drink or tap water that causes hyponatremia in patients such as QUB. QUB's diarrhea probably caused loss of potassium and bicarbonate through the GI tract, resulting in hyperkalemia and hyperchloremic metabolic acidosis. The potassium depletion can sensitize antidiuretic hormone secretion in response to hypovolemic stimuli, and the hyperkalemia can also lead to hyponatremia. The cellular efflux of potassium causes cellular uptake of sodium, further reducing the serum sodium concentration. The next question reads, how should QUB's hyponatremia be treated? The treatment of hypovolemic hyponatremia involves sodium replacement to correct the deficit. The sodium deficit can be estimated by the following formula. Sodium deficit is equal to total body water multiplied by (desired sodium concentration minus current sodium concentration (closed brackets). Sodium deficit is equal to 0.6 liter per kilogram multiplied by 70 multiplied by (140 minus 125 closed brackets). Sodium deficit is equal to 630 milliequivalents. Recall that total body water is equal to 0.6 liter per kilogram multiplied by weight in kilogram for men and 0.5 liter by kilogram multiplied by weight in kilogram for women. Approximately one-third of the deficit can be replaced over the course of the first 12 hours at a rate of less than 0.5 milliequivalents per liter per hour. The remaining amounts can be administered over the course of the next several days. The use of isotonic sodium chloride solution is ideal for the treatment of hyponatremia associated with volume depletion. As renal perfusion is restored, free water will be excreted with appropriate retention of sodium. Because QUB has only mild volume depletion, oral replacement fluids can be given. Oral solutions containing both electrolyte and glucose or rice-based solutions are ideal for the management of persistent fluid loss. Glucose not only provides calories but also promotes the intestinal absorption of ingested sodium. Because the rice-based solution provides more glucose and amino acids, both of which can promote intestinal sodium absorption, it is more effective than glucose alone. In patients with renal salt wasting, the ongoing daily sodium loss should also be taken into consideration when estimating the amount of replacement. Potassium should be given to correct hyperkalemia, thereby reducing the hyponatremia as well. The serum sodium concentration may rise faster than expected because as tissue perfusion is restored, sodium delivery to the distal tubules will increase and antidiuretic hormone secretion will be suppressed appropriately. In the absence of antidiuretic hormone, increased free water excretion will improve the serum sodium concentration faster than initially estimated. The next case reads, TWA, a 55-year-old man with a long-standing history of alcoholic liver cirrhosis, is admitted to the hospital for worsening shortness of breath. His medical history includes portal hypertension, esophageal varices, and non-compliance with dietary restriction and medications. His blood pressure is 120 systolic 60 diastolic. He has a pulse rate of 100 beats per minute. His respiratory rate is 20 breaths per minute. He is afebrile. Physical examination reveals a jaundiced man in respiratory distress. His jugular vein is flat and lung examination reveals bilateral basal rales. Abdominal examination shows tense ascites with hepatomegaly and spider angionas, telangiectasias resembling a spider. He has 1+ pedal edema bilaterally. Laboratory data on admission are as follows. Sodium levels of 127 milliequivalents per liter. Potassium levels of 3.4 milliequivalents per liter. Chloride levels of 95 milliequivalents per liter. Total bicarbonate content of 24 milliequivalents per liter. A BUN of 10 mg per deciliter. Serum creatinine of 1.2 mg per deciliter. Albumin of 2.5 grams per deciliter. Urine sodium less than 10 milliequivalents per liter. Osmolality of 380 milliosmoles per liter. identify the possible causes of hyponatremia in TWA and discuss its pathophysiology. How should he be treated? TWA had no history of vomiting or diarrhea and had stopped using diuretics before admission. The physical findings of ascites and bilateral edema are not consistent with volume depletion, but indicate a sodium excess state. Both sodium and water retention occur, but the disproportionate accumulation of ingested water relative to sodium leads to hyponatremia. Cirrhotic patients who are susceptible to developing hyponatremia have a decreased effective arterial blood volume. The low urinary sodium concentration suggests that the effective arterial blood volume was decreased. The high urinary osmolality in the face of hypertonic hyponatremia suggests, however, that the release of antidiuretic hormone has been stimulated, impairing free water excretion. Peripheral vasodilation causes decreases in systemic arterial blood pressure despite a normal to high cardiac output. This, along with splanchnic venous pooling and decreased oncotic pressure secondary to hypoalbuminemia, decreases renal perfusion in patients with cirrhosis, such as TWA. Decreased renal perfusion activates the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the release of antidiuretic hormone. Reabsorption of sodium and water in the proximal tubules is enhanced, diminishing sodium and water delivery to the distal segments of the nephron. The diluting capacity of the kidney is thus impaired. Increased secretion of antidiuretic hormone also promotes free water reabsorption at the collecting tubule and contributes to the hyperosmolality of urine and hyponatremia. The hypovolemic hyponatremia is also seen in patients with heart failure and nephrotic syndrome and in patients with chronic renal disease who drink excessive amounts of water. As the glomerular filtration rate decreases, distal delivery of sodium is reduced and the ability to generate free water is impaired. In addition, the capacity to conserve sodium is impaired in these patients. Most patients who are edematous and hyponatremic are asymptomatic, but the degree of hyponatremia probably reflects the severity of the underlying disease. Unless an acute decrease in serum sodium occurs, rapid therapeutic correction is not warranted. Water restriction, the mainstay of therapy, is determined by the degree of hyponatremia and the severity of symptoms. Sodium restriction and judicious use of diuretics may help reduce the edematous state, but the patient must be monitored closely to avoid prerenal azotemia, which suggests over-aggressive diuresis. Furthermore, diuretics can induce or worsen hyponatremia and volume depletion by impairing the diluting capacity of the kidney. TWA had abdominal paracentesis to relieve respiratory discomfort with no sequelae. He was then prescribed a 1000 mg sodium diet, and water was restricted to 500 ml per day. Diuretic therapy was resumed. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 370.